Very good evening, boys and girls. So, we meet again with another session of MCQs with us. And today we are going to start with MCQs on respiratory physiology. Right? So, I'm your mentor, Dr. Reena Kaur at An Academy. Right? So, let's get started without wasting time with the first MCQ of the day. A 12-year-old, right? Uh, Yes, so let's get started in a moment. Yes, so a 12-year-old boy has got a severe asthmatic attack and he is wheezing. Like, because he's got an asthmatic attack, definitely he's wheezing. And he experiences rapid breathing and he is cyanotic. His arterial PO2 is 60. PCO2 is 30. Which of the following statements are true, right? Which of the following statements are true in this context or regarding this patient? So as I tell you, right, as I always tell you that there is a clinical question. Whenever you are concentrating on the clinical question, try to find out the normal and the abnormalities which are being given to us. Like yesterday also I had emphasized on the same thing. ठीक है, तो यहाँ पर अगर आप देखोगे, like if you see it over here, the arterial PO2 is 60, right? The arterial PO2 is 60, that means the PO2 is less, and the carbon dioxide is 30, therefore carbon dioxide is also less. So just look into the statements which would just justify this, right? The forced expiratory volume, the forced vital capacity, that is FEV1 to FVC ratio, is going to be increased. The ventilation perfusion ratio is increased in the affected areas. The arterial PCO2 is higher than normal because of the inadequate gas exchange. Arterial PO2 is lower because of hypoxemia, that is leading to hyperventilation, or the residual volume is decreased. Yes, so Manish has come up with the correct answer. Very good, Manish. The correct answer is D. Right? So whenever you are getting a type of a question, it is not always related to obstructive and restrictive diseases, right? It is not always related to the lung volume and capacities. Always remember, the question can be in a different format, right? The question can be in a different format. Always, we are not interested in asking you the lung volume and capacities. So you can see over here that the arterial PCO2 is lower, right? Because there is hypoxemia. This hypoxemia is a very important stimulant, and it is going to stimulate the peripheral chemoreceptors. Because the peripheral chemoreceptors are stimulated, right? Because the peripheral chemoreceptors are stimulated, there is hyperventilation that is causing the person to expire out carbon dioxide, resulting in the respiratory alkalosis. So this patient is also going to have respiratory alkalosis. Now in obstructive disease like asthma, right, the ratio of FEV1 to FVC is reduced, right? The ratio of FEV1 to FVC is reduced because it is an obstructive airway disease. So what happens in obstructive airway disease? The decrease in FEV1 is out of proportion of the decrease in FVC, right? The decrease in FEV1 is out of proportion of a decrease in FVC, and these patients are going to keep on trapping air over a period of time, which actually results in increase in residual volume, increase in FRC, and increase in TLC, right? So the FEV1 to FVC ratio is going to be decreased. Poor ventilation of the affected areas decreases the ventilation perfusion ratio and causes hypoxemia, right? The patient's residual volume, tell you, as I told you, the patient's residual volume is going to be increased because he is already breathing at higher lung volumes. Okay, so here the question is asking us, about the cause of this decreased PCO2. Paul, you are saying his arterial PCO2 is higher than normal. Why beta it is higher than normal? The arterial PCO2 given is 30. That means already it is given 30, which is suggesting that the patient is suffering from hyperventilation, right? The patient is suffering from hyperventilation. Already question में दिया हुआ है कि PCO2 कम है, right? Now next one. Next question. a healthy 65-year-old man has got a tidal volume of 0.5 liters, has got a breathing frequency of 16 breaths per minute. That means this is being given as the respiratory rate. His arterial PCO2 is 41. PCO2 of the expired air is 35. What is the alveolar ventilation? Now we know that when we calculate alveolar ventilation, we need to have tidal volume minus the dead space, right? And this is to be multiplied by the respiratory rate. Though we are given a tidal volume, right, we are given the respiratory rate, we are not given dead space in this question. That means first we need to calculate, okay, first we need to calculate the dead space, and then we are going to calculate the alveolar ventilation. Now this is a very important type of a calculation based MCQ, which is always expected in the examinations, right? Now remember, it is the respiratory minute volume, which is also called as the pulmonary ventilation. It is simply respiratory rate into tidal volume. But we know that all of this RMV or the pulmonary ventilation is not available for gaseous exchange, right? Therefore, when we calculate alveolar ventilation, we subtract the dead space from it to actually get the amount of air which is available for exchange. So in this given question, first we need to calculate the dead space. Very good. The correct answer is D. Abhinya, very good beta. The correct answer is D. So just solve it. Alveolar ventilation, we know it is tidal volume, dead space volume ka difference, which we have to multiply by the respiratory rate, that is the breathing frequency. And the dead space has to be calculated from the given data. So this we are going to calculate by multiplying the tidal volume with the difference between the arterial PCO2, expired PCO2, and you're going to divide it by the arterial PCO2. So from this we get the dead space as 0.006 liters. We put it into the formula of alveolar ventilation, and this is the tidal volume minus the dead space, right? Tidal volume minus the dead space. We multiply it with the breathing rate or the respiratory rate, and we get the alveolar ventilation as 6.14 liters, right? So moving on next. Which person would you expect to have the largest alveolar arterial oxygen gradient? Okay, so you are asked about the largest alveolar arterial oxygen gradient. Person with pulmonary fibrosis, person who is hypoventilating due to morphine overdose, person who is at high altitude, that means 12,000 feet above sea level, a person with a normal lung breathing 50% oxygen, or a person with a normal lung breathing 100% oxygen. So you know that the normal alveolar arterial oxygen gradient is around 5 to 15 mmHg, and you are asked among the conditions given A, B, C, D, E, which one will have the largest one? Yes, anybody would like to make a guess about it? C. No. The correct answer over here is A. C is one of the most commonest wrong answer. It is the commonest wrong answer that is being given. Right? Now just catch up the explanation. What do you understand by an increased alveolar arteriolar oxygen gradient? This signifies that there is lack of oxygen equilibration between the alveolar gas and the systemic arterial blood. Right? There is a lack of oxygen equilibration between the alveolar gas and the systemic arterial blood. Now when you consider pulmonary fibrosis, what happens in fibrosis? There is a thickening of the alveolar pulmonary capillary barrier, that means the respiratory membrane, and therefore because there is thickening, right, because there is thickening, there is going to be increase in the diffusion distance for oxygen, and because of increase in the diffusion distance for oxygen, there is going to be a lack of equilibration of oxygen. There is going to be hypoxemia, and there is going to be increase in the alveolar arteriolar oxygen gradient. right? So in pulmonary fibrosis, where is the problem? The problem is in the respiratory membrane. Now, when you consider the person hypoventilating at high altitude. Now, if the person is moving at high altitude, whatever partial pressure of oxygen he is taking, right? Obviously, the partial pressure of oxygen is going to be less at high altitude. But according to that, the equilibration is going to be normal. There is no problem with equilibration, right? The arterial blood itself is going to be equilibrated with a low alveolar PO2. There is no problem in equilibration. If the person is breathing oxygen which has got a less partial pressure of oxygen, that is one case, but there is no problem with equilibration. So because there is no problem with equilibration, the alveolar arterial oxygen gradient is going to be normal. The change will occur only if there is a problem in equilibration. Person who is breathing 50% or 100% oxygen, he will have a high alveolar PO2. Now, if he's breathing a high alveolar PO2, then also there is no problem with equilibration. It is going to be, even if the alveolar PO2 is high, if the alveolar PO2 is high, the arterial PO2 will be high. But ultimately, the alveolar oxygen gradient is going to be normal, right? That means a problem with the alveolar oxygen gradient only occurs if there is a problem in equilibration, like which you get in shunts or ventilation perfusion mismatches, right? So if you are taking in less oxygen or if you are taking in more oxygen and there is no problem in equilibration, it is not going to affect your gradient. And remember, the normal gradient is 5 to 15 mmHg, right? So moving on to the next question. The pH of the venous blood is slightly more acidic than the pH of the arterial blood. What is the cause of this? A. Carbon dioxide is a weak base. B. There is no carbonic anhydrase in the venous blood. C. The hydrogen generated from carbon dioxide and water is buffered by bicarbonates in the venous blood. The hydrogen generated from the carbon dioxide and water is buffered by the deoxygenated hemoglobin, or the oxyhemoglobin is a better buffer than hydrogen than is deoxyhemoglobin. Now remember that even if you know the correct answer, it is always important that whatever exceptions are given to you, that means what other options are given to you, should be understood to you very well, because many times the question would be framed in the same manner, right? The options could be same, the options could be different, but the concept will remain the same. So the correct answer obviously is D, and here we are speaking of nothing but which is called as the chloride shift, or which is also called as the Hamburger's phenomenon. Hamburger's phenomenon, right? So coming on to the explanation, you know that in the venous blood, carbon dioxide reacts with water and produces carbonic acid. This reaction takes place rapidly because of the presence of the carbonic anhydrase in the RBC. Remember that this carbonic anhydrase is one of the fastest acting enzyme which is present in the body. It consists of zinc. It is present in RBC, but it is also present in the GIT. It is present in kidney. It is present in brain, right? But it is not present in very significant amount, or it is present in a very less significant amount in the plasma, right? Therefore the formation of the carbonic acid does not take place very rapidly in the plasma. Now, when carbon dioxide combines with water, right? When carbon dioxide combines with water, it forms carbonic acid, which is going to dissociate into bicarbonate and H+. This H+ is going to be buffered, right, by the RBC or by the deoxyhemoglobin. And therefore, the pH of the venous blood is slightly acidic. Oxyhemoglobin is a less effective buffer. So if you consider the RBC, right? This is our RBC. So what actually happens is, see, carbon dioxide is going to combine with water and it is going to form H2CO3, which will dissociate into H+ and bicarbonates, and this H plus will be taken care by the hemoglobin because hemoglobin is a buffer. This bicarbonate is going to be exchanged with another ion, right? It is going to be exchanged with chloride to maintain the electrical neutrality. Now chloride is osmotically active. So because chloride is osmotically active, it will also drag water inside the cell. Therefore, on the venous side, the cells are slightly swollen. Right? The cells are slightly swollen, and even the hematocrit is slightly more on the venous side than on the arterial side. This phenomenon is called as chloride shift or the Hamburger's phenomenon. This bicarbonate chloride exchanger is an example of counter transport. Okay, it is an example of counter transport. It is an anion exchanger, band 3. Okay, it is anion exchanger band 3. Right? So this is always one of the favorite questions which can be asked. It can also be asked in the form of image which is given to you, and you may be asked about this anion exchanger. Next is, compared with the systemic circulation, the pulmonary circulation has a higher blood flow, lower resistance, higher arterial pressure, higher capillary pressure, or higher cardiac output. Boys and girls, whenever you are studying, I always say that it is very, very important to know the peculiarities and the differences between the systemic circulation and the pulmonary circulation. Many of the times when we are studying, the circulation wala part is bit neglected, the coronary, pulmonary circulation. So I always, just try to keep a touch over those topics also. So here the correct answer is B, that is lower resistance. Now the blood flow or the cardiac output in the systemic and the pulmonary circulation is nearly equal, or sometimes you can say that slightly less on the pulmonary side because of the 2% of the systemic blood that bypasses the lung. Pulmonary circulation is supposed to be a low pressure and a low resistance system than the systemic circulation. The pulmonary capillaries, they show a very important phenomenon, right? The pulmonary capillaries, they show distension. This has come also in the form of an MCQ, and they show recruitment, right? They show distension and they show recruitment. This is a very, very important phenomenon which is shown by the pulmonary capillaries. Therefore, whenever there is increased demand, for example in exercise, the blood flow can increase without increase in the pressure because the capillaries, they show distension and they show recruitment. So one of the very, very important feature is a low resistance, low pressure system, right? Now, the diagram over here shows us 3 compliance curves, S, T, U, for isolated lungs who are subjected to various transpulmonary pressures. Which of the following describes the best, the relative compliance for the 3 curves? See, we know the concept very nicely, we know this graph very nicely. Only when it is posed, sometimes in the form of a graph like this, so we get confused looking at the graph, but there is no confusion regarding the graph, right? There shouldn't be any confusion. The options available are S is less than T, less than U, S is less than T but more than U, S, T, U are equal, S more than T, less than U, or S is more than T, which is more than U. Right? Now, the correct answer is definitely E. This is, suppose, you know that this is, if I take it normally and if I draw that this is a normal compliance. You know that when the graph is towards the up and left, it is increase in compliance, and when it is down and to the right, it is decrease in compliance. For example, this could be a clinical condition like fibrosis. This could be a clinical condition like emphysema. So only the graph is given in a very complicated manner. When we look at it, we find it very horror, but the concept is very, very simple, right? You can see that at any given transpulmonary pressure, where is the volume more? The volume सबसे ज़्यादा is in the S, then T, then U. Because on x-axis there is pressure, on y-axis there is volume. Whenever there are questions which are related to the graph, boys and girls always make a habit to look over to the x and y axis before you be very haphazard to mark the answer. Right? So just understand a bit concept. What is compliance? It is the change in the lung volume, right, at a given transpulmonary pressure, which is supposed to be delta V upon delta P. What is transpulmonary pressure? It is the pressure difference between the alveolar pressure and the pleural pressure, right? Remember, it is alveolar pressure minus pleural pressure. It can never be pleural pressure minus alveolar. It is always inside minus outside, and the transpulmonary pressure across the lung is always positive. If it is positive, it is going to prevent the collapse of lung. It will prevent the collapse of the lung. You have a transpulmonary pressure across the chest wall, right? You have another transpulmonary pressure across the chest wall, which is intrapleural pressure minus atmospheric pressure. This transpulmonary pressure across the chest wall is always negative. This negative transpulmonary pressure across the chest wall is going to prevent the over expansion of the chest, right? So you have got a positive transpulmonary pressure across the lung, which prevents the collapse of the lung, but a negative transpulmonary pressure across the chest wall, which prevents the over expansion of the chest wall. Now we know that compliance is equal to the slope of the volume pressure relationship, and it is clear that S represents the highest compliance, U represents the lowest compliance, right? Therefore, we had three curves and we said that S more than T, which is more than U. Now, coming on another to a graph related question. The question says, the maximum expiratory flow volume curve is being used as a diagnostic tool for obstructive and restrictive lung diseases. At which of the following points on the curve does the airway collapse limit maximum expiratory flow rate? Right? Again, the concept is known. The concept is asking you something about the effort dependent and about the effort independent portion of the expiratory limb, right? But it is designed in a way which is really confusing. And so which of the point shows the collapse limit maximum expiratory flow rate? The points which are given here, I would just 1 minute, I would it is A, B. I just draw it over here in case you're not able to see, because so the correct answer is D. I'll just draw it, right? Like this is the curve, this is the point A, this is given point B, this is given point C, this is D, and this is E, and we have seen that the correct answer is D, right? That means D is the point where the airway collapse is going to limit the maximum expiratory air flow. Now just look on to the explanation. The maximum expiratory flow is created when a person inhales as much as air possible. That is point A, which is depicting the total lung capacity. Then as he expires the air with a maximum effort, so that no more air can be expired, that is point E, which is the residual volume, right? So see point A, this is the point where there is TLC, point E, which is the point which is the residual volume. So this was the starting point. He started inspiration, he started his expiration because the air, lungs were full with air, right? And now he expired out and the air remaining is residual volume. Now, as you know that when we speak of the descending limb, the downward limb, This descending descending portion of the curve is what is representing the expiratory flow rate at a given lung volume. The descending portion of the curve is sometimes also referred to as the effort independent portion. You know, up till this point where you get the PEFR, this limb of expiration is supposed to be the effort dependent. That means if you increase your effort, the PFR can be more. Whereas this descending limb totally reflects effort independent. That means even if whatever effort is made, you cannot bring about any further increase in the amount of expiratory air. So the patient cannot increase expiratory flow rate even to a higher level with whatever expiratory effort he is expended. Right? Next. Cheyne-Stokes breathing. Right? All of us are aware what is Cheyne-Stokes breathing. It is an abnormal breathing which is characterized by a gradual increase in the depth of breathing. Right? There is a gradual increase in the depth of breathing, followed by a progressive decrease in the depth of breathing. So there is first increase and then there is decrease. And it is going to repeat. I'm going to show you a diagram. Which of the following points which are from V to Z, right? Which of the following points which are from V to Z are associated with highest PCO2 in the lung and highest PCO2 in the neurons in the respiratory center, right? So you have to tell me that which is the point at which there's going to be highest PCO2 in the lung and highest PCO2 of the neurons in the respiratory center. So now you can look over the options A, B, C, D, E, the points from V to Z where you're going to get highest PCO2 in the lung and highest PCO2 in the neurons. So the correct answer is B, that is point V and point W. Point V and point W. V where there is highest PCO2 in the lungs and highest PCO2 in the neurons in the respiratory center is point W. So just looking over to the explanations. You know that the basic mechanism of Cheyne-Stokes breathing, right? The basic mechanism of the Cheyne-Stokes breathing is attributed to a building up of a carbon dioxide. So because there is building up of carbon dioxide, there is stimulation and there is overventilation. Because of overventilation, you know there's going to be carbon dioxide washout and there is going to be a depression of the respiratory center, right? Now it should be clear that the greatest depth of breathing will occur when the neurons of the respiratory centers are exposed to the highest level of carbon dioxide, that is the point W. Right? So the depth of breathing is going to be maximum at that point where the respiratory centers are exposed to highest level of carbon dioxide, which is shown in the diagram as point W. The increase in breathing causes carbon dioxide to be washed out and the PCO2 of the lung is going to be lowest. So that point where the PCO2 of the blood is lowest is the point Y. Right? So point W means maximum carbon dioxide level, which is stimulating the neurons, and hyperventilation is resulting in carbon dioxide washout. So a decrease or the lowest level of carbon dioxide is at point Y. So the carbon dioxide of the pulmonary blood gradually increases from Y to Z and it reaches its peak or its maximum value at point V. Thus, it is the lag phase between the PCO2 at the respiratory center and the PCO2 of the pulmonary blood that results in this type of Cheyne-Stokes breathing. So we all are aware about the cause of the Cheyne-Stokes breathing, about the nature, but the question is really interesting because it has put us in a very different form where you have to tell the highest point of carbon dioxide and the lowest point of carbon dioxide, right? This lag phase can be seen in conditions like left heart failure, enlargement of the left ventricle. Therefore, the time increases for the blood to reach the respiratory center. Cheyne-Stokes breathing you can also get in head trauma, in stroke and brain damage. Now coming up next is you are being given graphs A, B, C, D, E, F. You have to tell which of the following oxygen hemoglobin dissociation curve corresponds to the blood from the adult and from the fetus. So red is for the adult, right, and green is for the fetus. So you have to tell which of this graph is depicting that of the. So the correct answer is C. Now even I think the F is hidden by my shadow, but it doesn't matter because the correct answer over here is E, right? So if I just tilt, I mean it's okay. It's E. No, sorry, it's C. Now again I told you, when you are getting this multiple graphs, the question becomes very scary. But don't forget that you know the basic concept. That means what is the affinity of fetal hemoglobin and what is the affinity of the adult hemoglobin and what are the causes for that affinity. Which one is going to show a left dissociation and what is the reason. If you know these, again the question does not become very difficult to be understood. You can see in green a left shift and a red is comparative towards a right shift. This is the adult hemoglobin and this is the green one is the fetal hemoglobin. So just look on to the explanations. You know that there are structural differences between the fetal hemoglobin and the adult hemoglobin, right? Adult hemoglobin is alpha 2 and beta 2. The fetal is alpha 2 and gamma 2. And the 2,3-diphosphoglycerate level, right? The 2,3-diphosphoglycerate level is going to have more affinity with the beta component. It has got no affinity for gamma. The fetal dissociation curve is shifted to the left in comparison to the adult curve. Now, even if the fetal arterial oxygen pressures are low, there is a left shift of the curve which enhances the placental uptake of oxygen, what you also called as the double Bohr effect. Double Bohr effect, what happens is on the maternal side, you know that there is comparatively more H plus, there is more CO2 which shifts the curve to the right. Now because it shifts the curve to the right, oxygen reaches the fetal side. Suppose this is the placenta and the fetal having comparatively less CO2, comparatively less H plus, the curve shifts to the left which enables binding. So the fetal circulation or the placental circulation shows a double Bohr effect. Now a 67-year-old man has got a solid tumor that pushes against an airway and causes a partial obstruction to the distal alveoli. Which point on the ventilation perfusion line of this oxygen carbon dioxide diagram corresponds to the alveolar gas of these alveoli? So the answer is already given. It is A. Right, you can see that this graph is plotted taking the oxygen, partial pressure of oxygen on the x-axis and that of the carbon dioxide on the y-axis. Now you know that when the ventilation is reduced to zero, that means when the ventilation perfusion ratio becomes zero, alveolar air equilibrates with the mixed venous blood that is entering the lungs. That means here the composition of the alveolar air will be same as that of the venous blood, right? The composition of the alveolar air will be same as that of the venous blood because there is no ventilation. So because there is no ventilation, the alveoli are not receiving any fresh oxygen, neither the carbon dioxide is removed. Therefore, the composition of the alveolar air is going to be same as that of the venous blood, which is occurring at point A, where the alveolar PO2 is 40 and the PCO2 is 45. Now you can just look at this diagram, boys and girls. See, this is the normal ventilation perfusion ratio. This is the point where the ventilation perfusion ratio is infinity. What is infinity? Here there is ventilation but there is no perfusion, right? There is ventilation and there is no perfusion. That means the numerator is normal, right? But the denominator is zero. Therefore, the ventilation perfusion ratio is said to be infinity. This can occur in conditions like pulmonary embolism, right? It can occur in conditions like pulmonary embolism. So here the partial pressure of the gas is going to be same as that of the alveolar air. That means oxygen near about 150 and no carbon dioxide, because we are not inspiring carbon dioxide as such, right? So when the ventilation perfusion ratio is infinity, that means there is no perfusion, the composition is going to be same as that of the alveolar air. On the other hand, if the ventilation perfusion ratio is 0, what do you mean by that? This means that there is no ventilation. That means there is numerator is 0 and denominator is normal. So when the numerator is 0 and the denominator is normal, it comes to 0. So the ventilation perfusion ratio is 0, which can occur in any kind of obstructive airway diseases or any kind of obstruction, which could be a foreign body or which could be a tumor, as which is given in this question. Now here what will happen, because they are not receiving air, right? The alveoli are not receiving air. So the composition will be same. The composition of carbon dioxide and composition of oxygen is going to be same as that of the venous blood. That is oxygen 40 and carbon dioxide 45. This is one of the very, very important high yielding MCQ to be remembered for any kind of examination you are going to give up, right? So with this, boys and girls, we come to an end of today's session. We meet tomorrow again 9 p.m. and I'm going to look forward with cardiovascular MCQs. We'll have MCQs and discuss cardiovascular physiology. Please always take time to rejoice, because when you rejoice, you can restart with full refreshment so that you can refocus towards your goals. So remaining a very positive attitude, let the stress be a goal of motivation. Don't convert the stress into distress. Life will always have challenges in some or the other form. Rather studies are the least challenge which you have to face. So with this, boys and girls, just giving you an idea about the Plus subscriptions, where you can assess both the live and the recorded classes. Iconic subscriptions, where you get a combination of Unacademy with Prepladder. Our special class features, like the classes are interactive. We conduct polls, raise a hand where you can speak to the faculty. We give you notifications, you can download and you can have it anywhere. We are coming up with important free test, so please look upon to that. We are starting up with a revision series of FMG as well as Target NEET PG, right? So with this, boys and girls, I come to an end of this session, and thank you for your patient learning, and happy learning always. Thank you.